Good evening, everyone, and good evening to you, Dr. Karamanian. I appreciate you taking the time to talk to us this evening. Thank you very much.
Thank you for having me.
Not at all. What I think we'd like to do is give you about 15 minutes or so to give us some initial background on where you think people are in the use of focal laser ablation today, and a sort of general overview dealing with the different types of FLA, the types of patient who you are seeing, and where we are in the development of this technique, which obviously has potential, but obviously also we're missing a lot of data as yet.
Yes, that is definitely one of the criticisms of any emerging technology. You can't have long-term outcome data until it's been done for a long time. But that's obvious. So let me explain sort of where the origin of this is, where the origin of MRI-guided focal laser ablation came from, and then how we got to where we are and where we look to be going. So traditionally, when you do a biopsy in any organ looking for cancer, you use some sort of imaging guidance to see your target and use that to direct a needle into that target. You wouldn't do a blind biopsy of the prostate, of the breasts. You wouldn't do a blind biopsy of the lungs, or you wouldn't do a blind biopsy looking for liver cancer. It's all done with image guidance. Unfortunately, up to very recently, we didn't have a good modality for image guidance where we could actually target a lesion in the prostate. There's been some work with ultrasound, but unfortunately, the sensitivity is extremely poor for clinically significant prostate cancer. Now, with the advent of prostate MRI and multiparametric MRI, we've improved tremendously in our ability to actually image the prostate and find lesions in the prostate. It's not perfect, but it's really been a huge breakthrough. And so the first step was to do MRI-guided biopsies, where we can see a lesion, oftentimes missed on a truss biopsy, and then put a biopsy needle directly into it in order to get a sample. And there are many studies that show that, especially after a negative truss biopsy, an MRI plus a targeted biopsy leads to much better sensitivity for a clinically significant prostate cancer than just a repeat blind truss biopsy. Blind truss biopsies are non-targeted in the sense that they don't look to hit a particular lesion, but they are systematic and segmental in that they go through systematically through the prostate, but only a small portion of the prostate is sampled. So now there's MRI-guided focal laser ablation. There's also ultrasound or fusion-guided focal laser ablation. I want to make a brief distinction here, talking about the two guidance technologies. So there's the guidance technology, and then there's the actual ablation technology, the source of energy that causes tissue death. And there is such a thing as MRI-guided HIFU. There's ultrasound-guided HIFU. There's MRI-guided focal laser ablation. There's ultrasound-guided focal laser ablation. MRI guidance has tremendous advantages in that you can actually see the lesion directly with the MRI in real time. Also, MRI is able to measure temperature changes of the ablation tissue, of the tissue that you're trying to ablate in real time as you've turned on the laser and as you're doing the ablation. And what we found is that in some men, you need to increase the power of the laser to get it to the temperatures that you want. In other men, you don't want to turn the power of the laser on quite as high. And that real-time MRI feedback during the ablation helps us to do that. It helps us make those judgment calls. And it also helps us to create a structure of the ablation in such a way that we're able to get up to the capsule without extending beyond it. That's clearly the goal when you're trying to destroy a cancer, that goes right up to the capsule without letting that ablation zone go beyond the capsule where it can hit the nerve. So now I'd like to speak mainly about MRI-guided focal laser ablation. The reason being there have been a couple studies with ultrasound or fusion guided focal laser ablation. Unfortunately, the data on those patients, the short-term data in terms of oncological control is rather poor. When you have ultrasound-guided ablations, the current studies that have come out from the NIH and that have come out from UCLA show that a very significant portion of those patients have residual cancer that was not effectively treated. But I would attribute that not so much to the laser, but to the guidance technology. It's like sending a missile in to destroy a target. You have to the missile might offer a great explosion, but if the guidance doesn't take the missile to the target you're trying to hit, you're not going to destroy the target. And MRI offers tremendous advantages in using it in real time during the ablation.
If I may just quickly, so what you are talking about is what some of us would describe as in-bore laser ablation, correct? I just want to get that out there because that's a term that I think people have probably heard, but they may not have been fully aware what it meant.
No, and I appreciate that clarification. I have seen at least one urologist describe real-time MRI imaging guidance, but he actually meant fusion guidance. So it's important to make the distinction regarding, from the perspective of a patient, to ask, am I actually in an MRI during the procedure or not? Because really you need those MRI images to be acquired during the procedure in order to improve that level of precision. And so there are two main approaches. One is a transrectal approach, where a guide is placed through the rectum in order to angle directly towards the cancer. Another option is a transperineal approach, where the device is laid in the perineum, which is sort of the bottom part of the pelvis, and then guided into the prostate that way. Most practitioners are doing it transrectally. The distance to the lesion is shorter that way. It could be argued that it's a little bit easier to put the laser fiber precisely where you want it to go, but it's mainly based on operator experience. There are some other techniques that are used to try to minimize side effects, such as injecting a dilute amount of lidocaine or fluid around the nerve in order to provide some thermal protection of the nerve, so that when you ablate right up to the edge of the capsule, the fluid can absorb some of the extra heat that's coming off as opposed to the nerve absorbing it. When we do the ablation, the MRI in real time tells us what sort of temperature changes we're creating in the tissue, and then it also, at the end of the procedure, doing a contrast-enhanced MRI, shows us whether or not we actually killed the region of tissue that we intended to. That's sort of the moment of truth, so to speak. So currently, we have short-term data, and I know it's frustrating. Believe me, I'm looking forward to the long-term data being developed as well. And I tell every potential patient that we don't have long-term data showing, for example, improved overall survival versus, say, no treatment, or comparing it to surgery. What we really need is a long-term trial that has patients, that are prospectively randomized into different treatment arms, such as surgery, radiation, MRI-guided focal laser ablation, HIFU. The thing is, though, with low and intermediate risk prostate cancer, you really need 10 to 15 years to get good outcome or relevant outcome data. As a matter of fact, the PROTECT trial, which did this with radiation and surgery, just recently came out. And you know how long we've been treating patients with radical prostatectomies and radiation therapy. Also, another argument along these lines is that the first data that really showed that surgery had improved survival compared to no treatment wasn't published. The first prospective study that looked at that wasn't published until 2005. And at that point, I'm sure that there were many, I don't know, I have an exact number, but I would guess that hundreds of thousands of radical prostatectomies had been performed prior to that sort of data being published. And so with any new treatment, you have to look at the short-term data, look at it with some, and you have to look at it with some reservation. And patients need to know that going into it so that they can make an informed decision themselves in terms of where they place.
Again, if I may, I think this is
Sure.
one of the issues that we're very interested in. Clearly, we all understand that nobody's got even 5-year data yet. But certainly some people must have 2-year data by now, which would give you some idea about the risk for side effects and the risk for complications at the time of treatment.
Sure.
And I personally am disturbed that those data haven't been published by anybody, because I know there are at least 2 physicians that could publish a series of data with that information.
That's correct. Let me comment on this. So, first let me talk about what has been published. So, the largest studies to date for MRI-guided focal laser ablation have come out of NYU and the University of Chicago. Chicago's was up to 1 year. NYU's, they did a biopsy at 3 months after the focal laser ablation procedure. Now, in terms of side effects, the side effects are, if they don't occur within, most of the side effects occur close to immediately in the perioperative period. We haven't really seen delayed side effects that occur a year or 2 years out. And that's to be expected with this kind of technology. The safety profile for focal laser ablation, again, there have been multiple studies that have looked at the safety profile, which show that it has a fantastic safety profile, especially compared to the more traditional forms of treatment for prostate cancer. The question in my mind is, what is the long-term oncological control data going to show? The short-term oncological control data, for example, in the study from NYU, showed that after doing an MRI-guided rebiopsy of the lesion of ablation, showed that 96% of the time there wasn't residual cancer in the area of ablation. That's probably that we're probably not going to be able to achieve those kind of results in the real world, but that gives you an initial sense of what the at least short-term efficacy of it is. In the University of Chicago, in their study, they did a biopsy at 3 months and then at 12 months, and that showed not quite that level of control, but also very good short-term control in the zone of ablation.
Now, were these in patients with known clinically significant disease, or were these in patients who we might be looking at today and saying, well, they should be on active surveillance anyway?
Well, the NYU paper emphasized the point that 80% of the patients in their study would not fit the Johns Hopkins criteria for active surveillance.
Okay.
So we should talk about active surveillance a bit, because that really does play into this significantly. One of the big problems that we've had up to very recently is doing appropriate risk stratification. What do I mean by that? So there was a very nice long-term study out of Johns Hopkins that showed that if you have Gleason 6 disease, that really is Gleason 6 disease, your chance of dying from that are 0. There are a few scattered cases of Gleason 6 that has metastasized, but we're talking like much less than 0.1 of 1%. So if it really is pure Gleason 6 disease, then do you really need to treat it? Active surveillance is, in those cases, a very good option. The problem, though, is that with the Johns Hopkins study, they had the benefit of looking at all of these prostates, the whole gland, so they could determine that those Gleason 6 diagnoses really were Gleason 6 diagnoses. The problem in real life, though, is that you don't have a whole prostate to look at under a microscope when you need to counsel a patient regarding whether or not they should seek treatment. And that, again, goes to the point of risk stratification. If you have a patient who undergoes a trust biopsy, comes back with a Gleason 6, how sure are you that patient really only has Gleason 6 disease? There have been a variety of studies on this. Most of the data ranges between 30% and 70% in terms of patients who originally had a diagnosis of Gleason 6, what percentage of them were upgraded at surgery? What percentage of them actually had Gleason 7 disease, but thought they only had Gleason 6 disease based on the trust biopsy? Well, since one of the arguments that urologists have made, and with some degree of with some reason to it, is that, well, if you have a 6 on a trust biopsy and you actually have a 50% chance of having a Gleason 7, should we proceed with a radical prostatectomy? Now, that's led to a tremendous amount of overtreatment. And so one of the tools that we've been using to minimize that is MRI with a fusion or an MRI in-bore biopsy in order to better risk stratify those patients. So that way we can have a higher degree of confidence that a patient who has a Gleason 6 diagnosis really only has Gleason 6 disease. And then with greater confidence, we can recommend active surveillance. Or if they have a Gleason 6, the MRI shows something significant elsewhere in the prostate, get a targeted biopsy, and let's look at that other sample. And if that turns out to be, a Gleason 4+3, well, then active surveillance wouldn't be appropriate. And so MRI has, just to summarize, MRI has really advanced risk stratification and then focal treatment. It's really enabled that.
So would I be right in thinking that all of the patients who come to you asking about FLA, if they have Gleason 7, you will do it, assuming that it's a relatively small amount of Gleason 7, and if it's Gleason 6, you will say to them, well, let's make sure that you aren't really Gleason 7 and do a repeat biopsy under MRI guidance of some type.
Well, it gets a little bit complicated. If a patient wants to, a lot of it, also take into consideration, a lot of it comes down to patient preferences. I can make my recommendations, but the decisions really come down to the patient. So if I have a patient who has a Gleason 6, that's small volume on truss, gets an MRI, the MRI is negative, I'll definitely recommend active surveillance. If the patient has a small volume or has a Gleason 6 on truss biopsy, gets the MRI, and the MRI shows a lesion that corresponds to the Gleason 6 seen on pathology, then I'll tell them, look, active surveillance might be a very good could be a very good option for you. Let's talk about it. And if they say that they really would like to. Active surveillance is a good option for them, and that's what they'd like. I look at the pathology and see if it matches up with the MRI. If it matches up and the MRI isn't too suspicious, okay, let's leave it alone, get a repeat PSA MRI, in a year. If the MRI looks like it's more suspicious than the pathology results from the truss biopsy would indicate, then I'll tell them, we should proceed with an image-guided biopsy, and I would recommend fusion or in-bore, depending on whether or not I think the fusion biopsy would be able to hit that lesion, because there is some misregistration with fusion versus, say, an in-bore biopsy.
So that would be a patient with a PIRADS score of 3, right, or higher, right?
It gets so PIRADS. It would definitely be 3 or higher. But it gets a little bit more complicated than that. PIRADS really is a simplification of findings. Sure. So now, if a patient, let's say a patient comes with a Gleason 3+4 that's 30% Gleason 4 and has, 1 centimeter of length on the biopsy, and it has a concordant MRI lesion, and it all fits together appropriately. Then I'll offer them MRI-guided focal laser ablation. There are patients who have Gleason 6 disease and tell me, look, I need treatment. I cannot go without treatment, And I'll push active surveillance, but patients will push back. And one of my patients recently told me, look, if you don't do focal laser ablation, I'm going to go have surgery. I can't leave that inside of me. Then in those patients, I will agree to do an MRI-guided focal laser ablation. So we should move on to talk about what patients are good candidates for focal laser ablation.
Sure.
So if you have if there's the ideal patient, I love it when I get these ones because it's straightforward, technically easy, and we've noticed in that we get good oncological control on these patients. An 8 mm single focus of Gleason 7 that has a good amount of distance between the neurovascular bundle and the edge of the lesion. By a good amount of distance, I'd say maybe 1 centimeter. Those patients are fantastic candidates, especially if if the quality of the MRI is great and there isn't much confounding on the rest of the prostate. If the rest of the prostate looks clear and we can see things clearly on the MRI, I love taking care of those little guys. Now you can also ablate 2 separate foci, maybe 3. That's pushing it. Beyond that, or if there's diffuse disease, then I tell patients that they're not good candidates for focal laser ablation. And obviously, I talk to all patients about a variety of alternatives. But then I would, with patients who have diffuse disease or really tremendous multifocal disease, I would decline to do a focal laser ablation.
So if I may, when you've got a patient with two foci like that, are you more comfortable if they're both in one lobe of the prostate or both in one quadrant of the prostate? I mean, in other words, we obviously all worry that this can be disseminated disease, even though it's multifocal disease, even though one can only see 1 or 2 small foci. How much confidence do you get from the sort of the positioning of 2 foci as opposed to 1?
Sure. So if they're right next to each other, then I take out that whole area. If they're separate from each other, then I take out the one with plus a margin, I take out the other one plus a margin. It's technically a little bit easier to do them if they're next to each other, but either way, it doesn't make a tremendous difference, whether they're in separate lobes or if they're right next to each other, so long as the morphology, the size, the characteristics of the lesions are favorable, then it doesn't make a tremendous difference whether they're in one lobe or 2 lobes. The issue does come in where I've seen, unfortunately, where there's a lesion in the peripheral zone next to the neurovascular bundle, one on each side, and that significantly increases the risk of having sexual side effects. If you have to ablate right up to both nerves, your risk of sexual side effects does go up, and that's where it becomes an issue.
And would you usually be able to tell patients beforehand that might be a problem?
Always.
Okay, thank you.
Sure. Let me just briefly talk about, as a clarification point, there is green light laser for prostate. That's completely different. Green light laser is used through the urethra. It goes into the penis, goes to the prostate with a camera, and the urologist cuts out chunks of prostate tissue in order to improve the symptoms of BPH. That's completely different than MRI-guided focal laser ablation for prostate cancer.
So to summarize, basically what you're telling us, I think, is that by doing in-bore FLA, you are able to help the patient by using up what you believe to be a less invasive technique that as far as you are aware, the short-term outcomes are pretty good for most patients. But clearly we're going to need long-term data. And I get the impression you are saying that you believe that the in-bore technique is a great deal more effective than truss MRI fusion-guided FLA. Is that a fair summary?
More. Yes, tremendously more effective because you can target the lesion directly, measure temperature changes as you're doing the ablation, and you can do a post-treatment MRI that's contrast enhanced to see the effectiveness of the ablation itself directly.
So the language that people use to talk about techniques that are in this stage of evolution is obviously important because payers will currently be classifying this technique, I believe, as experimental. People like me tend to use the word investigational. I don't think anybody's going to be saying that this is a fully validated way to treat prostate cancer yet, but certainly it's very attractive to a lot of men because they think of it as lumpectomy or the equivalent of lumpectomy for prostate cancer. And I worry about, and I don't mean this unkindly, but I worry about the skill levels of the people who may be offering this at the moment and how a patient is able to get some clarity about that. I mean, for example, how many patients have you personally treated this way as yet?
Sure, 42.
Okay.
And I know that's not a tremendous number like 500 is, but I did complete a fellowship in interventional radiology, and I've done cryoablations for renal cancers, microwave ablations for liver cancers. I've done easily over 1,000 types of 1,000 interventional radiology procedures, and one of the benefits of the MRI guidance is it gives you very real-time feedback in terms of the quality of the work that you're doing. So if you're a good prostate diagnostic radiologist and can see what you were able to accomplish or what you may not have done as well as you would have liked to, if you're able to see that immediately, then that gives you real-time feedback in order to accelerate your understanding and skill level much more quickly. The people who are doing this at volume currently are, it takes a great deal of skill to be able to do this well. And so I do understand the reservations of, being a new technique. I mean, look, if a patient goes to, I wouldn't hesitate to have a patient go to, whether it's Dr. Walser or Dr. Feller or Dr. Sperling or to myself, a patient's going to have, I believe that the patient, I would feel comfortable sending a patient to any of those practitioners for this.
I mean, my understanding is nobody's done 500 patients as yet. I mean, in other words, my understanding was Dr. Walser might have done a couple of hundred himself by now. Is that about right?
Yes, Dr. Walser's done roughly around 220, plus or minus 10 or 15. Dr. Sperling reports that he's done more than 500. Dr. Feller in California, I don't know the exact number that he's done, but it's definitely over 100.